Parallel session on cooperation in public health. We are starting a little late, but hopefully there will be an interesting discussion. We have 5 distinguished panelists with us. Dr. Ganga Tilakratna, Research Fellow and Head of Poverty and Social Welfare, Institute of Policy Studies of Sri Lanka. And then we have Dr. Syed Abdul Hamid, who is the professor at the Institute of Health Economics at Dhaka University. We have Dr. Prabir De, professor at Research in Information System in Developing Countries, RIS, India. Dr. Sabina Faiz Rashid. She is professor of Mushtaq Chaudhry Chair in Health and Poverty, BRAC James P. Grant School of Public Health in Bangladesh. And we have Dr. Rudra Sawal, Lead Coordinator Economic Development Program of the Nepal Development Research Institute. And we have, of course, a distinguished set of participants too, and I would encourage those sitting at the end, if you'd like, you can come forward. We'll get started, and the theme, as just mentioned, is cooperation in public health. And the speakers, the panelists would, of course, draw both on their own country experiences and implications for the theme of regional cooperation. So we'll get started with Dr. Ganga Tilakratna from Sri Lanka. In terms of time, I'll request panelists to stick to about 7 to 8 minutes, so that we also have some time for floor discussion. Dr. Tilakratna.
Thank you, Chair, and good afternoon to all of you. First of all, let me take this opportunity to thank CPD for inviting me for this very important event. Although South Asian countries have made some progress in terms of the health outcomes, we know still South Asia is still among the regions with the lowest life expectancy and the highest mortality rates and highest incidence of infectious diseases like TB, only sort of second to the sub-Saharan Africa. And also the government expenditure on health care, if you see, it's actually about 1% for most of the countries, which has in a way contributed to the low coverage in the access to health. But when you look at the countries, actually the outcomes have not been even across the 8 countries. And the stories behind also, there are differences. Now, if you take Sri Lanka actually implemented the universal health policy in 1940s, giving access to free health care services to its entire population. So, which in a way helps Sri Lanka to achieve significant achievements in terms of health outcomes like mortality rates and life expectancy and so on and so forth. So, for example, now maternal mortality rate in Sri Lanka is currently about 33 deaths per 100,000 live births, which is actually much lower compared to the other South Asian countries, and also it is lower than the East Asian average. In fact, the global target set by the SDGs or the 2030 agenda is 70 deaths per 100,000 live births. So Sri Lanka basically achieved this target about 2 decades ago. So even in terms of the mortality, child mortality rates, and Sri Lanka's actually performance is quite relatively higher, and the country has also achieved near universal immunization, and also nearly 100% births are attended by the skilled health personnel. So these are all due to the universal health, free health policy that we implemented a long time ago, and the heavy investments by the government some years ago. So, but things have changed over time. So currently the government expenditure on the health system has come down. So it has come down to less than 2%, even though it's higher than many countries. But now the out-of-pocket expenditure on health has increased. So almost 50% is actually out-of-pocket expenditure. So which has led to issues in the health sector in terms of quality and equity. And also there are shortages of medicine now because of the economic crisis. also has affected the recent economic crisis in Sri Lanka, which has led to sort of shortage in medicines and other medical supplies in a lot of the hospitals in the rural areas, and also there is also a shortage of health professionals because of the increasing out migration due to the economic crisis, which is actually a result that has, that we see recently due to the economic crisis. So most of these issues are actually not unique to Sri Lanka. So we know they are actually common to many South Asian countries. So it just, we have kind of started facing some of these things recently now because of, the things have changed. So to address these gaps and issues, to ensure universal health coverage, so many initiatives needed to be taken at the country level as well. And the regional cooperation also can help achieving the targets. In this context, actually, there are many ways that regionally, bilaterally, or as a region as a whole, that we can actually collaborate through experience sharing and learning from each other and best practices and all that. So I would like to touch on three key sort of areas that I thought are important, perhaps looking at from the Sri Lanka's perspective too. So one area is actually digital health or telemedicine. So collaboration in digital health or telemedicine services across South Asian countries actually can help improve access to medical professionals and particularly access to certain specialists who may not be available in certain countries. So it can also help address the issues of shortages in health professionals in countries. So this is actually, telemedicine is something that has been widely sort of become popular or used in some South Asian countries during the COVID-19 pandemic to provide access to those who are in remote areas. And there are examples of cross-border telemedicine collaboration also within South Asia. I've heard of something called e-Swaftwaya between Nepal and India, which basically provides Nepali patients to get access to Indian doctors. And there's something with, I think, an initiative between Bangladesh and India called Teledoctor. These are things actually that can be promoted across the other South Asian countries also, bilaterally, or it can be regionally. So regional level sort of digital platforms or telemedicine services are sort of, I feel it's a good area that actually we can collaborate to improve access to quality health care in the region. So another area that I want to talk about is the collaboration on controlling infectious diseases like TB or COVID-19 or even dengue, which is actually quite specific to certain regions like South Asia, which is not so common in some of the developed countries. So where the attention is actually and the funding is limited from other countries when it comes to research and development. So we can actually collaborate through let's say setting up early warning systems for emerging infectious diseases like COVID-19 and establishing regional disease surveillance networks for real-time data exchange, and also investing in research and development to prevent and cure diseases like dengue. So my third area for collaboration that I think there's a potential for collaborating and the region would benefit is collaboration in pharmaceutical production and access. So which is an important area for collaboration, which can actually reduce the cost of essential medicine and ensure better access to medicine by all countries in the region. So however, we know that the region also faced number of challenges in developing and producing its own pharmaceutical products, such as due to lack of capacity, technology, resources and regulations. So collaboration is actually on pharmaceutical production by sharing resources, knowledge, technology, and by harmonizing policies is something that actually we can consider. So one possible way that South Asia can collaborate is by establishing regional training hubs and technology transfer platforms, perhaps to help building skills and capacities of local pharmaceutical manufacturers, and also developing regional supply chains and facilitating trade that can ensure availability and accessibility of essential medicines and vaccines within the region, which can actually involve reducing tariff barriers and improving quality standards, and supporting perhaps pool procurement, etc. too. So, and also South Asia can pool resources for research and development for essential medicines and vaccinations. So these are some of the areas that I want to highlight. Thank you.
Thank you so much. There was really in short time, but you really laid out both the Sri Lankan experience and also the areas where regional cooperation in the health sector could proceed. Thank you so much. Can I now invite upon Dr. Syed Abdul Hamid, Professor, Institute of Health Economics, University of Dhaka. 8 minutes again, eh? 8 minutes again.
8 minutes,
yeah.
Okay, thank you. I think Bangladesh picture we almost know who are presenting here, but I will just point out 2-3 issues. The Bangladesh has had some good progress in many health indicators, but struggling in achieving the SDGs goal. That means goal 3.8. That is the USC. So USC, achieving USC, we have a lot of challenge, especially the health financing challenges. Out-of-pocket payment is too high, maybe the highest in this region. We have some other problems, especially we have good drug manufacturer here, but there are a lot of issues regarding the quality of drug and other issues. I think there is a lot of scope of collaboration among the South Asian countries. That means Bangladesh can get benefit from cooperating with the South Asian countries in many areas, especially the areas which are basically the common areas, because we have some shared health challenges among these regions. I am mentioning some of the shared health challenges. One of them is infectious disease control. We faced a pandemic, and we have seen that when there is a big wave in India, we could predict at that time that the wave immediately will be coming in Bangladesh. And those who have protection in the border, but we could not protect it. That means the wave immediately come in Bangladesh. So this type of the infectious disease is a big challenge. So if we basically handle this type of issues jointly, then it is beneficial for all these countries in this region. So what we can do in this context, we can have surveillance, that is common surveillance systems, and we can have joint research initiative on vaccines and other issues to prevent and control this infectious disease. Then non-communicable diseases. That is a bigger issue in Bangladesh and maybe the other countries. I'm not sure. Maybe it is also a problem in the Sri Lanka and the other ones. So one of the major problem of the communicable disease is not discussed much in this type of gathering. I think that is one of these major issue is the drug trafficking. That means in the South Asian countries, a lot of drug trafficking is happening because we in Bangladesh do not produce any narcotics, but the narcotics is available here. That means it's coming from the cross border, it's coming from the Myanmar, it's coming from the other countries. So that need to be basically taken care if we want to take care of these non-communicable diseases. And other non-communicable diseases that we can have collaboration on awareness campaign, prevention programs, and the treatment protocols that we can do. Then there is we have a scope of development of the health infrastructure. That means sharing expertise and resources in healthcare technology, telemedicine, and health information system. As you rightly mentioned, that we could have the digital platform of the health system. So that is an issue. And also we have a scope, as Ganga rightly said, that we have a scope of capacity building. That means exchange program for medical student, researcher, and health administrator as well. Then there is a scope of research and development. That means shared resources for the clinical trials and studies on prevalent health issues in South Asian countries. We have lot of scope because emergency response is a big issue here. Often these countries, the natural calamities often occur here. So at this time, if there is a big natural calamities occurs in Bangladesh or India or Sri Lanka, then the other country can quickly respond. So we need to set that mechanism so that we can handle this type of emergency response quickly. Health information definitely we can do, collaborating on health surveillance system as I mentioned earlier to monitor and respond to the health issues. Then we have some common cross-border health issues and we can do joint initiative to manage and control this the movement of this infectious disease. And we have also a scope for nutrition and food security issues that is also related to the public health, especially implementing region-specific strategies to combat malnutrition and ensure access to nutritious food. And we have also a scope for health diplomacy and policy coordination, coordinating health policies and regulation to ensure consistency and effectiveness across border. We have also a lot of scope, the traditional medicine, improvement of traditional medicine. I know that some countries are much advanced in traditional medicine, especially India. We can also get knowledge from this. But doing all these things, we need to have some platforms. Other than platforms, it cannot be happens. And we also need to have common funds. So platform and that platform need to be backed by the fund. So if we can, all these countries can come into these common health challenges, and how can these common health challenges can be basically respond, and if this country come into the common interest that we will have an organization to respond to these issues, and there should be building a fund. That would be very much effective. Thank you, sir.
Thank you, Professor Hamid, and particularly your last point about the need for vehicles through which the cooperation will move ahead, platforms and fund. Thank you. I'll now call upon Dr. Prabir De of RIS, India.
Thank you very much, sir. Mr. Chair, I'm not a public health expert. I look at the other, go with the colleagues of CPD. I look at it more as a point of view for the regional cooperation, the integration of the public health. And I haven't done any work so far on the public health. I don't have any paper, neither have written any op-ed as well. So whatever I'm going to talk, it was just my sheer interests and experiences. On the subject, I'm learning and following all others. But I read in one serious article, and that was edited by Professor T.N. Srinivasan, and there was a chapter on trade in health services. Way back, I think 20 years back, and contributed by a gentleman sitting next to my right hand, Professor Mustafizur. And I read it and got motivated. Later on, when I did a study for the Secretariat with the support of the ADB on the trade in health services, that helped me a lot. So I acknowledge the contribution. Mr. Chair, I go by the previous speakers that diseases, they don't follow the border. It is a cross-border, more or less. And in great example, the pandemic time, we realized the shared challenges. And as you know, that in the March 2020, towards the end of March, we went into the lockdown, and it's the whole story is very well documented. But if you recollect, we never activate such process to look at the public health challenges. Suddenly, leaders, they met together to deal with the COVID-19 pandemic. The first time in the history of the SAARC, the political leaders, they came together to talk about the regional cooperation on the pandemic challenges. That was the first time. But as soon as we came out with gradually 2020 or 2021, there were a couple of follow-ups, but it then fizzled out. Now here I bring one example of the ASEAN, because organizers added here the experience of Southeast Asia. And when I talk about the Southeast Asia, I was heading one ASEAN India Center for quite a long time. My experience is that COVID-19 pandemic and other transborder public health challenges is actually strengthen the regional cooperation in case of Southeast Asia through ASEAN. three ways they activated, and on permanent basis. It's not that the leaders met and then they disappeared after some time. That at least going to the ministerial meeting to dealing with the public health has to be permanent. So this is one. They have been regularly doing at least one meeting in a year nowadays. Second, there are guidelines issued by the ASEAN Secretariat to all the member states to follow certain operating procedures, the norms and regulations. ASEAN 10 countries, and there's huge differences. On one hand, you have Laupedia, where they don't have doctors in a way. On the other hand, you have Singapore, So here, Singapore took a lead to give it come as a regional panacea for looking at the public health. And then utilizing the capital in the region for the health and medical facilities, particularly driven by the Singaporeans. So these three things I have noticed, and these are continuing. Let me come back to the region where I belong, and what we have done. And I will some anecdotes about what India has been doing. And basically, what we see that in Indian constitutions, public health is in the Schedule 3, means states and center both will be dealing with the public health jointly. So fair amount of laissez-faire is given to the center and state to deal with in the public health services, but there are quality differences. And if you go to the state of Bihar, where the fatalities are very high, but when you come to the state of Tamil Nadu, where are much better facilities, and I'm sure from Bangladesh, they prefer for the treatment to Tamil Nadu and Karnataka. Now, there are many developments, but post-COVID, 3 examples I can give that is India has done. One is the vaccine, and there are 4 or 5 type of vaccines. Nowadays, we don't follow who has introduced the new vaccines for COVID-19 or through the several other mosquito diseases or something or other. This is going on. We do not follow up anymore. But that time, India introduced the vaccine one by one, as well as the application, the CoWIN platform, where it's well managed, and then later on these were become a role model, or many countries have followed. Post-COVID, if you look at our leading newspaper, the death rate among the youngs below 40, and doctors are telling, I see Indian Council of Medical Research, the death rate, particularly the heart attack because of the COVID vaccines, has gone up heavily. So these are not the economists are telling, the doctors are telling, and this has been reported in the front page in the media. So we should be a bit careful. After all, health science is not physical science. There are lots of issues. So this is some other side of the health. But one, the COVID vaccines, CoWIN platforms, and the state level. What I have found, particularly the state of West Bengal and the state of Delhi, these 2 states I frequently travel, and where those are the poor of the poorest, they cannot afford. Both the states, they made everything free for them. So in India, we have a very popular health card. Every state has a different names. Since our insurance and banking system is very settled and very stable, we have no issue up to 5 lakhs. If anybody who's having a health card walk into the private and public hospitals for their treatment, that has been given huge advantage to dealing with the diseases and health treatment. So these 3 examples could be something for other member countries. Maybe they have done much better than these 3. Last, what Dr. Ganga and others are telling, application of telemedicine and teleeducation. These 2 are fairly successful when India look at Africa. But there is a strong diplomatic insights here. Sometime you need to tell diplomacy to take the back door. We don't need. So anyway, the Bengalis look at diplomacy not in a right spirit. আমরা ডিপ্লোম্যাট নই, আমরা সাধারণ মানুষ, এই কথাটা বলছি আর কি আপনাকে। So but India's introduction of telemedicine and teleeducation to the Africa is very good, very positive, but there is other angle which I am trying to highlight, diplomatic angle. That's something. For South Asia, I think it can be introduced here if other countries participate, go by the 2 previous speakers. So way forward, if we look at the shared challenges in the public health, as an ordinary person, I can place something for the table, for the proceedings to be noted, is that since many patients from this part of the world, they go to India and other countries, we can think for the facilitation purpose. I know their miseries. I know because I speak in Bangla. Shuddha Bangla kotha boli ami. So when they speak to me what their problem, I know what's happening. Bangladeshi patients, the special problem they face. So I think SARC visa for health treatment, kind of in long term, multiple entry long term, with a patient plus 2 of the patient parties can be given. That maybe we need to tell to the Indian High Commissioner within. That is very important. Plus, the payment is another issue. So here, if we don't make it a very stable payment, then informal market comes in, unorganized sector, which is a great loss. So payment systems we need to be formalized, and the reactivation of SART network of doctors and nurses and health workers. Those are in India. We have a very strong network on the health workers. So also in Bangladesh. But they don't meet each other because some family relatives, they work there, so I know the thing is. Last, that we have in Bangladesh called Beximco, is a great multinational pharmaceutical company. They don't come forward even if there is a joint initiative for discussion on the pharmaceutical collaborations. They don't come. Let me be very, very frank on it. Because of their business strategy. They think that if we meet in a regional program, they lost more than the gain. So maybe we need to reach out our, from there, and joint explorations of medicines, vaccines. Those would be some of my recommendations. Thank you very much, sir.
Thank you so much, Dr. Brigade. Particularly this point about facilitating medical tourism. Yeah, I think that's a suggestion that perhaps we will review later. Now I want to bring in Dr. Sabina Rashid. She is the professor at BRAC, James P. Grant School of BRAC University.
Thank you. Good afternoon. I'm Sabina Rashid. I'm with the BRAC James P. Grant School of Public Health. I'm going to take the conversation slightly into, I teach. So I teach and I do research. And I really want to talk about if we want to help health and health of the poorest, most disadvantaged, and then we get into health systems, health sector, trade, policies. If I take it back to education, and we really want to create the next generation of public health leaders, I want to mention some key points, and I promise to try and stick to time. But really, why is South-to-South collaboration in education, university, curriculum, teaching, learning, research, more critically important than ever? I think it's actually extremely urgent. Post-COVID, but even pre-COVID, we're living in a world that's struggling from endemic poverty that's deepened. You've got climate change. You've got all kinds of crisis. You've got post-COVID crisis. You've got education sort of loss. And you've got inequalities deepening in our country, but in many countries, and they're very, very much struggling. Now, how is that reflected in our education or curricula system at the university level? Well, one, we need to decolonize knowledge and decolonize our educational systems. At the university, there's a tendency to cut and paste from the north. And there's nothing wrong with cut and pasting some technical knowledge, but really if we want to look at contextualized knowledge, we really need to look at it's very skewed in public health. The value systems are skewed, and those who can articulate and synthesize knowledge are definitely or not always engaged in practice. And I think we need to bring practice back into our education and knowledge, teaching and learning, and even in our research and our tools, if we want to create leadership in public health for better public health outcomes. My second point is we've had examples of health systems where we have learned from each other. We've had practitioners teach. Now that's a new concept because in many developed countries, faculty has a certain kind of criteria. That's problematic because in our context, and if you look at institutions in South Africa, where I've been part of these regional groups, they have practitioners teaching because a practitioner with 20 years of experience may have much more knowledge than a faculty who's just joined and who's going to teach on a topic. It might be economic loss, it might be social inequalities. A key point is community-based teaching and learning. Many of the similarities around this region is that we don't actually want to learn from our communities, nor are they part of our teaching and learning in practice. Of course, we're trying to do it at the School of Public Health, at BRAC University, and possibly other institutions, but this should be the heart of every curricula. Why are communities missing in research, in teaching and learning? If we want to improve health and understand policies, systems, their priorities and needs, the teaching has to start from the bottom up. And then finally, I wanted to say that we need to look at ways forward. And ways forward is equitable, meaningful partnerships. Not partnerships that we come and we just show deference to another form of knowledge without understanding and interrogating the very knowledge base we have. Our rich traditions, our history, our capacities, our ability to find solutions, innovations in our own country, respective country context, because there is a lot of knowledge. And we have also institutions, BRAC, Grameen Bank, GSK, and even in India, SEWA, that become case studies for teaching and learning, creating the next generation of public health leaders. So my challenge is, if knowledge is power and it's controlled by institutions that are not invested in understanding what our needs are, then we need to radically push back and change the way knowledge is understood, what we teach, how we teach, and it means faculty like us have to also unlearn the way we've been socialized to teach. Thank you very much.
Thank you, Sabina. Wonderful bringing in another angle to this whole discussion about health education, in particular the importance of the knowledge and practice linkage. That's a very important point. And the last point that you mentioned about knowledge has to be a space in which we are also pursuing equality there. It cannot be a one-way traffic from a giver to a recipient. It's a shared learning approach that we have to undertake. Thank you so much for emphasizing those points. And our last speaker on the panel is Dr. Rudra Sawal from Nepal Development Research Institute. Dr. Sawal, please.
Thank you, Chair, and thank you, CPD, for giving this opportunity to speak something and to share some of the ideas. Is Dr. Prabir, like him, I'm also not an expert of this public health, and I'm a economic account, that is national account person. So I'm not a expert of this subject, but I have reviewed some of the literatures and some my opinion, personal opinion, and I have put how it comes. Let me go to the context. I mean, of the situation of health situation of SAARC countries. So, some countries are really ahead in the indicators, health indicators, and some are very in a low status. There is big disparity among the countries in the South Asian region. So the disparity between among the countries is also a serious thing that we cannot say just South Asia. So there is big differences and disparities among countries. We can see from the data that there is huge differences, And as Dr. Ganga mentioned that Sri Lanka is far ahead in terms of indicators, and the other countries are behind. So, exchanging the idea among the countries, like Sri Lanka, can share the idea or the knowledge, the skills, and the capacity to other countries. So, as she mentioned at the last that there is necessary of institution. Without institution, it will not be possible. So there should be some institution. And in the past, I think in terms of maternal mortality is also there is a huge differences, and doctor population ratio is also the same. There is difference, and the stunting of children under 5 is also like this, and the fertility rate. And this is the just to see the context of health in South Asian countries. So SARC has initiated, in fact, SARC is now we had a lot of discussion that can SARC be activated, or SARC is dead, or what. But anyway, SARC, other regional organization, any other organization need to work on this issue, health matter, like in other areas. Health is some organization, institution, regional organization should should work on this matter. Going back to the SARC, the health in a social chapter, that is later in SARC Summit Colombo, July 1996. There is social chapter was introduced at that time, and in that chapter, health and nutrition was the one topic. Based on that, so I don't want to go in detail, but there are some activities and progress on health, especially health and population work. So in different SARC summits also, the health issue is raised in some summits, but not in all, but in some. And there is one center, that's TB HIV AIDS Center, HTSC, that is in Kathmandu, located in Kathmandu, and it is, in fact, it has done very good job through this institution, and it has got made some strategy also. So it is, I think, it is a very one of the successful action that SARC took. An emergency meeting of SARC Health. There are so many ministerial level meetings held in different times. So it has raised some of the issues and some recommendations or some guideline has prepared at that time. But how much it is implemented, that is another part. We can, but there are some initiation made, and especially there are some there is some technical committees, and during the COVID-19 period, there was some conference, virtual conference of the head of the states and head of the government was held. That was also, I think, it was a very good example of that SAARC initiatives and SAARC activities. So that is one telemedicine network project is there, is working, and it is anyway, it is underway, it is working. So this type of activities needs to be strengthened and upgraded, I think, in the days to come. And now coming to the context, the public health in the sector of public health, globalization has led to a new health challenges and also opportunities also. So to work with these new challenges, there is a need of some upper level, I mean regional, maybe sometime in global level organization should play a role in this. So because health issue has become more challenging in especially in recent years because of this, because growing interdependence is growing between nation states. Many of the activities cannot the state only, the nation cannot do alone. So interdependence, because of this interdependence and large range of actors in health sector also, large range of actors are involved now, different types and different level. And national governments no longer able to hold sole responsibility for the health of the people. Health risks extend across borders, and as we mentioned earlier, as you discussed, and the challenge, the changes in health trends have led to the demand for global health governance and policy making. And the South Asian region is particularly prone to public health threats because of poor living conditions and high poverty rate in the region.
All right.
Okay.
If you can finish in 2 minutes.
Okay. Promoting social health insurance systems targeting the people who are, we can, I heard from the Sri Lankan experience and from Indian experience that you have already insurance scheme. So it can be learned by other nations. In Nepal, it is just started, but it is not going, well. So a lot of problems, issues are there. So the regional, I mean to say that the regional institution or some institution should coordinate these things. That's the thing. And in the present context, local government bodies and civil society organizations should work together to implement the health insurance scheme, and this is one. And okay. Regional cooperation framework is necessary. It should be to set standards and norms of health, and like SARC standard, we could say, or something like that. So, regional cooperation framework needs to be developed, and some vertical and horizontal integration is necessary. Similarly, uniform type of policy, health policy management and cooperation in the region. So, sorry, whatever. Okay, to conclude, in our region, the shortage of resources, especially funding, is the main problem to enhance health services. So, it should come from the political commitment, and that because without commitment, there is provision of in every budget and in every program there is many health service provisions are there, but there is a deficiency of resources, funding. So it is one of the problem. So commitment should come from the government, and technology, as we mentioned, telemedicine and all this type of technology should be transferred among member states, and to integrate and to make uniform standards, common strategy plan is also needed. That's all. Thank you.
Thank you, Dr. We want to open the floor. Thank you all the panelists for setting the stage. Open the floor for some discussion. We'll request whoever wants to speak to also be mindful of the time, about 2 to 3 minutes max, 2.5 minutes I would say. So it's open. Who would like to? Mustafiz, please.
Thank you, Chair Zilur Bhai. No, I think I learned a lot from the session. All the three who are experts, who we know, and the two who made the disclaimer that they are not experts, but they also came up with a number of very useful suggestions. First of all, we have seen during the COVID how regional cooperation in terms of vaccines have worked, and as a citizen of Bangladesh, this is also an opportunity to say thank you to our Indian friends for that. I think that this discussion is very important because 3 of the countries which are graduating from the LDC group, Bangladesh, Nepal and Bhutan, we have been enjoying the under the TRIPS waiver for pharmaceuticals, the need to buy patent and license for drugs. Now Bangladesh has gained tremendously from that. Of the $4 billion of our domestic market, 98% is Bangladeshi medicine. We also export to about 110 countries, about $160 million. And Nepal, Bhutan and other countries have benefited from the low cost medicine that we could produce because we had this waiver from buying patents and license for pharmaceutical drugs. That will be gone beyond 2026. So the point that I am making is that beyond 2026, the whole ecosystem of medicine and production of medicine will be changing, and the need for regional cooperation will be that much stronger. I will give you just one example. For example, insulin. The price of insulin will go up by 8 times, 800%, if we need to buy patent and license beyond 2026. So that is the ecosystem, and that is the world that we will have to prepare. And from that perspective, I think deepening regional cooperation, some of the suggestions that have come is very important.
Thank you.
Thank you. I must congratulate the panelists for excellent deliberation. I just wanted to highlight one point is that the discussion about the regional cooperation on this public health, we may fall into the kind of danger into, probably cooperation more, when you talk about public health, probably more of private health, probably that is very much on the surface. Because as we have patients actually going to India, we know that many patients from Bangladesh, they're going to go to India, and actually they spend their own money. It's not that a state is taking care of it. So the out-of-pocket health expenditure is actually, even if you take into account the current pattern of cooperation, what is there, is actually contributing quite a lot to the out-of-pocket health expenditure, private health expenditure. What I'm trying to say is that if you really want to have a meaningful public health cooperation, countries like Bangladesh spend very poorly on public health. And the quality of public health is very poor. Quality of spending, efficiency of the spending is very poor. So unless and until we emphasize on our own, developing our own health structure, we will not be able to effectively participate in this regional cooperation. Sri Lanka is in a much better position. If you look at the Sri Lankan data, and which other panelists showed that, Sri Lanka in 1990 actually started from a very better position than any other South Asian countries. That means then Sri Lanka in 1990 was in a much better position, especially the way they spent on public health. And then by 2020 or 2021, the improvement was obvious. So that's why probably when Dr. Ganga, she was mentioning that at this moment Sri Lanka doesn't spend much, probably in proportion to GDP, but actually they have spent or invested quite a lot in the past decades. But we have not been able to do that. Bangladesh, what I call it policy paralysis, last 3 or 4 decades, same level of less than 1% of GDP on public health. I think that is something what we really need to emphasize on. Thank you.
Thank you, Salim. Please. And if you, for the benefit of the crowd, if you introduce yourself.
Sure. I'm Shekhar Shah from India, and it's a pleasure to be in a panel with Zilur. I'm sorry I missed the first 2 presentations, but I thought that, and I had spoken yesterday in the plenary about education and health being 2 areas where there could be very significant dividends. Just to pick up from Mushfiq's concern about the loss of the preferences, India is the generic pharmaceutical industry's capital, in the sense it's the amount it produces, and if you go to the US and get a prescription drug, more than likely it's made in India, and you can actually see it on the label. So it's generics as well as branded. So if there's a South Asian agreement, and certainly this could even be bilateral between India and Bangladesh, then some of that generic formulations could easily be sold in Bangladesh. So there are lots of opportunities in this way. I'm thinking much more of the approaches and the instruments that can lead to this kind of cooperation. And the one example that we have that has worked very well is I believe it's a quarterly meeting, but I could be wrong, maybe it's half yearly, of the power secretaries of the countries in the region. I believe they meet in Bangkok, or at least when I knew about it, that's where they met, in a sense, in a neutral venue. But that has built up a tremendous amount of trust in the energy sector, and indeed is the foundation of the energy projects that are now emerging, especially between India and Bangladesh, but also Nepal, Bhutan, India and Bangladesh. So I believe that if we can promote, and if one of the suggestions that we can put forward is that there should be these meetings, not the ministers, because then it gets political, but at a technical level, the health secretaries of the countries in the region meet, and obviously they'll meet with an agenda, and they'll have to show some outcomes. So that will put the pressure on them. And similarly in education, and the two obviously, as Professor Rashid has mentioned, are related, because health education is a very important part of public health. I also want to just be a little humble and say that while India may be a large country, it has a lot to learn from Bangladesh in terms of public health. ORS came about here. And because of the strength of the NGO community and their integration into the population, Bangladesh offers a tremendous opportunity for research at the community level on a large scale. And if some of you follow the work of Mushfiq Mubarak at Yale and the work that he did on devising strategies for the adoption of face masks, that experience and the norm model that he used led him, and I know this because I was working with him in India, led him to, and his group, to distribute about 100 million masks in a way in which they were fairly certain of the high probability of adoption. So there's a lot that Bangladesh can also teach the rest of South Asia in this respect, and BRAC, of course, is at the leading edge of that kind of work. So I just want us to be a little conscious that India may be a big country, but it has a lot to learn as well. Finally, just on health insurance, while insurance markets are developing in India, there's a lot yet to be done. And if you follow through qualitative work, a normal average citizen of India going into a health facility hoping to use the health card that he has been given, there are many things that need to be improved still in terms of the actual service and quality of service and the ease of access of that quality of service. So the region as a whole has a lot to get to. Thank you very much.
Thank you so much, and great to meet you, Shekhar, again. Yes, do you mind if I give the floor to the lady first? Yeah. Please go ahead, and please introduce yourself.
Thank you. I'm Professor Nahid Akhtar Jahan, Institute of Health Economics, University of Dhaka. Thank you, Chair, and the panelists, and raising many important issues for collaborating in improving public health situation in Southeast Asia. I would just like to reiterate some points here that we can see from the figures that the out-of-pocket expenditure is high, still high in most of the Southeast Asian countries. There are some exceptions, like Maldives. They have, have high level of coverage, and they have succeeded for health insurance. But due to economies of scale, they are sending their patients to other countries for treatment, and government pays the bill. So this shows us how a government can take responsibilities and still maintain economies of scale, economies of scope, and also ensure quality of health services for their citizens. Now, from Bangladesh, we know that a lot of patients are going abroad for treatment. So we cannot ignore the private sector because we have high out-of-pocket expenditure. So to achieve universal health coverage, we need to include the private sector in our financing schemes. Like we have to have some sort of increase the public financing or health insurance and improve the quality of the private sector. So we have some international physicians and doctors practicing in Bangladesh, but we didn't see any other staff, which are very important part for health service delivery. So if we can increase the competitiveness, like ensuring other health workforce from other countries coming to our countries, so it will improve the quality of the services as well. A few days, I think few weeks later, I was watching a news that some international hospitals, they are willing to establish their hospitals in Dhaka and some other cities as well, I think Chittagong. So these type of initiatives, I think the government could think that we should encourage. That will increase the quality of services, competitiveness, and pricing as well. Because pricing is a very important factor in health service delivery, because there are lots of variation in quality and price as well currently in Bangladesh. So in those areas, if we ensure free market and ensure that the physicians are coming and some hospitals are coming in Bangladesh, and also from Bangladesh, you know, health workforce can grow abroad. For example, I have told that Maldives, they are hiring also and they are sending patients abroad. And just other some points that health only do not depend on healthcare, public health. There are other social determinants of health which are very important for public health. So in those areas, I think there should be collaboration as well. And some of the public health interventions are discussed in these sessions, like immunization, vaccination, but there are some other interventions like wash, sanitation, and insecticide nitrate, because we have some malaria prone areas. So in those areas we also need collaboration, I think, beyond the health sector. So thank you very much.
Thank you very much for expanding the discussion to the social determinants issue. Very important point. Please.
Yeah, thank you.
If you'd introduce yourself.
Yeah, my name is Bhuvanak Perra. I'm the Secretary General of the Ceylon Chamber of Commerce. To add to what Dr. Tilak Ratna mentioned, in Sri Lanka, to give you a little bit of landscape in terms of pharmaceuticals in Sri Lanka, we are very much dependent to the other countries for the pharmaceutical requirements. You will not believe 92% of our medicines have been imported. Only 8% is manufactured, and that 8% is manufactured by 15 companies, out of which one is a government institution, which is the state corporation, and all those are generic drugs. Out of the 92, once again 60 or 65% is imported from Bangladesh and India. So there's an opportunity. Then coming to the health standards, up until 2001, the Sri Lanka private sector hospitals were very much local, and until Dr. Reddy of India set up operations in Apollo Hospital, set up operations in Colombo, since then I think the standards of hospitals have gone up leaps and bounds, and that was a good inroad that they made. In terms of Maldives, what this lady mentioned, yes, a fair amount of patients are coming to Sri Lanka and they patronize especially the Apollo Hospital. But something what I know of is that since lately in Maldives, the government has come to an understanding with Kuwaiti Fund, who is funding some of the hospitals. They are putting up 25 hospitals in each selected islands. Each of those hospitals is about 25 to 30 bed hospitals, small hospitals. May not be able to do some of the big surgeries, but having the infrastructure alone is not enough. They need to have personnel, the professionals, medical professionals, as well as the other. That is something what they need. But this is something which is happening in the region.
Yes, at the end, please go ahead first. The gentleman at the back hand, he raised his hand first. After him, then you. Please introduce yourself.
Thank you, Chair, for giving me the opportunity. My name is Khaja Masham Fahim. I'm from East West University Economics Department. So my question was that is there any possibility to have a health insurance package that will be available for all the SAARC members? So let's say a Bangladeshi goes to India, so that health insurance will cover their health bills. And with this way, out of pocket expenditure will be reduced. Also, people will trust this insurance as all the SAARC members will fund it. So that's my question.
I'm just picking Shekhar's brain. Does EU, for example, has such a possibility that a German patient will get his thing covered in Switzerland if he travels?
I don't know the answer to that, but certainly it seems like it should be the case because it's borderless, it's visa-less. So,
but in the health, in this insurance,
the infrastructure should be there.
Okay.
And there's one currency, so payments are not an issue. So all the ingredients are there. I don't know if they've moved to that stage.
Okay, good.
But it does mean that some of the ingredients would have to be here. Like you couldn't have visas
Exactly.
if you know if you took 3 months to get a visa.
Exactly. But that person and then yourself.
Thank you. My name is Zahid. I'm from ISEC in Bangladesh. So it's not that a question. I would like to just know, how does poor diet affect public health? As in Bangladesh, the poverty rate is more than 20%. So most of the people can bear their cost for medicine. If I give an example, like during pandemic times like dengue or COVID, the most of the pharmacists, they make artificial crisis of medicine. Like couple of days back, I was infected by dengue and I was looking for a saline that is especially for dengue people, but I couldn't find any of them. So it was so hard for them, and many people has died till now by cause of dengue. So the thing is, how does poor diet affect public health, as we are not that much rich country? Thank you.
Thank you. Please go ahead.
Thank you, Chair.
If you could introduce yourself.
Yeah, thank you. My name is Haruna Rashid. I work for Lighthouse. It's a civil society organization. We work for the urban people health services, particularly those people lagging behind. So I really learned many things from the presentation from panelists, particularly this out of SAARC country. We found that Bangladesh and Nepal side by side, their indicator says almost the same service we are getting, but Sri Lanka actually in 1996 they were in the 20.1%, and now it is 2.2%, probably the under 1 to under 5 mortalities. So that's a fantastic job. Actually, they were in the good position since 1996, and we were really was in the worst situation, and we are slowly crawling and getting really in good shape, Bangladesh and Nepal. However, the good sense is that some of the things we can still argue this. I support Dr. Shekhar regarding the some of the common dialogue, although we are not having the summit, but at least we can have a dialogue in that during intellectual dialogue for the technician or for the policy maker can be done. It can be online as well. There is no tension in between national or international, but it can be. I do support strongly to increase our collaboration. But regarding the mental health and the herbal the health services, India is doing much better than other countries I see within the SAARC country. So we can also leverage the scope, or how we can exchange or scale up this collaboration in between or among other countries. We can also look into this matter. And one more thing regarding the coverage of universal health, particularly I don't know, in Bangladesh only 13% of urban people become able to reach health services. But still we need to have, in urban population currently 38 to 42% roughly in Bangladesh, but only 13% we become able to serve. So we need to give attention on that issue definitely, but I need to hear from the other countries what are the coverage existing they have urban population. Thank you very much.
Thank you. Anyone else? And Mustafiz, as your CPD representative, I'll treat you as that. How much time do you think we can have to finish? 10? Let's say 15. We'll finish at 4. All right? Okay, so we'll close the floor. Oh, there is one more. Please go ahead.
My name is Shahriar bin Kabir from Jahangirnagar University. Bangladesh, one of the most disaster-engaged countries in the world, is also severely exposed to climate change impact with the multitude health complexities. My question is how our policymakers can take policy regarding climate change impact on the population health in Bangladesh, and how they design the policy, environment construct and health system preparedness against such climatic challenges. Thank you.
Thank you.
Just to answer your question about the European EU health card, there is I just looked it up, there is a European health insurance card, but it works this way. So if you are insured in your own country, then with that card traveling to another EU country, you will be treated the same way as if you are a resident of that country that you are visiting. But it requires a health insurance in your own country. So this could be a good incentive for countries to develop domestic health insurance industries.
Wonderful. Mustafiz.
Just 30 seconds. I have read that in Kerala, the government has issued health card. It's like a credit card. So to people under certain level of income. So they can go to a pharmacy, use that as a credit card. So I think the amount, I don't know, 1,30,000 Indian rupee or something like that. Okay. So that's really very novel, and it works. It goes through the digital, your wallet, and you can spend it like a credit card.
20 minutes, so we have to make sure that we use it. So I want to come back to the panel for 1 minute answers, all right, to a particular question I posed to each of you. So starting with Dr. Ganga, Sri Lanka, we have this picture, and we heard from the Sri Lankan Chamber of Commerce also. So you did go ahead in terms of a social policy on universal coverage, way back from the 40s, right? But what we heard is that the infrastructure in terms of, for example, domestic pharma production has not happened. You are importing. Is that a problem, or which gets priority? Is it getting the policy in place first and let the infrastructures develop, or do you have to really is, for example, a domestic pharma industry in Sri Lanka, is that a priority?
Yeah. I think the focus initially actually was on the policy to give free health services. So infrastructure in the sense, so we have a very good health, I would say a relatively good public health system, decentralized system too, primary health care and the maternal and child health. So the system, that is also infrastructure. So actually we invested a lot in those systems, and on the, I think the health professionals and even the nurses, midwives. They are actually quite skilled. That's why 100% of the births are actually attained by the skilled professionals. But I think we probably didn't invest much in these pharmaceuticals and that kind of technology kind of things. So probably being a small country, because we probably it probably would have been cheaper to kind of get out from outside. But now that at this moment we are faced with this economic crisis and then foreign exchange issues and all that, so we feel it more because when we are faced with a forex problem, so we had actually huge shortage of medicine, and we had to, we were actually supported by India and Bangladesh both. Okay. Yeah.
Just to add one into that, to support Dr. Tilakaratne, long years ago when we were small, there was a policy called Senaka Bibli policy for this manufacturing of pharmaceuticals in Sri Lanka. But unfortunately, the government after government did not implement that. Now we are facing the wrath of it. Sorry.
So for Professor Hamid, there was a question: how does poor diets impact on the issue of health? In terms of this discussion we are having today, how do you see that? Is that an issue of regional cooperation, or where do you place that issue?
Yeah, basically the poor diet is related to the nutrition, and nutrition is a big part of the health, and it's basically the preventive health. So that need to be addressed first, because nowadays TB is a common, though we have good progress earlier in the TB treatment, TB prevention, but the TB has come back in many forms. So the main cause of the TB is the malnutrition, So this type of things that need to be addressed, and that is also related with the poverty and other social issues, as Dr. Jahan has mentioned. So if there is a scope, we should have this collaboration a cooperation with the regional countries. But the question, as the other speaker has raised, we had an organization that is SAES. I think the SAES is not working now. It's a dead organization. So the countries need to have common interests to build, because here some countries are advanced. Suppose India is advanced in many contexts, but will they cooperate with Bangladesh and other countries? That is the question. So the Indian politicians and the Bangladeshi politicians, other politicians come to in common phase, so that this type of issues can be addressed. So we are talking. It's because we are talking here. This is our scope to talk. But the politician is not here. So who will hear that? This type of talk. That means we need to collaborate with the politicians to build such type of organization like SAES or other things. So that need to be taken.
We'll come back to the issue of who is more important, politicians or professionals. But I want to finish with the panel first. So Sabina, for you the question is, you mentioned that yes, health education is a critical area to look at, because at the end of the day, good quality service will require good professionals, trained professionals. But in terms of the talk of cooperation that we are having today, do you find that there is the mindset is ready for cooperation in the area of education among the SAARC countries?
I think first we have to fix our own mindset within the country. Cooperation is second. I'm pushing for a shift in the way we understand what content and curricula should look like, who are the knowledge bearers, and how do we value our own knowledge and feed that into education. The second step is then looking into cooperation. And I think once we have that shift and you find similar allies, it doesn't have to be hundreds, it can be one or two institutions which we've worked with in the past, you can create small changes because you can create a space for more critical discussions and interrogation of what we're teaching. Is it critical competencies? Is it relevant contextually? How do we learn from practice? How do we bring in practitioners? How do we learn from real sort of leadership organizations, from communities? So yeah, that would be my, thank you.
Vide, I mean, for you the question was, you made an interesting observation that Beximco, good producer here on pharma, not very proactive in terms of discussion regional, because their business strategy is not in sync in that sense. So how much of a barrier do you see here? The private sector, when you're talking regional cooperation, is a good idea, but the private sector thinks in terms of the market, in terms of profits. So what is your sort of hope or expectation that the private sector can also get into a regional cooperation mode? Is there good prospects on that?
Absolutely, there is good prospect, but I do not know. What are the barriers? I haven't done any study, but my personal contact with the Beximco, with some friends and etc. There are issues that maybe industry association through the B2B platform, they will be able to give it an answer. But before that, short intervention with discussion on the health card. Professor Mustafiz given a reference to the Kerala government. I can tell you with some credible information that West Bengal state government, under the leadership of Chief Minister Mamata Bandyopadhyay, they introduced a Shastro Sathi card in Bangla. Shastro Sathi, with a credit top up with the 5 lakhs rupees. 5 lakhs. So, and since, as you know, in India, insurance market is market driven, fairly strong, and it's working pretty well. And there is a follow up by the government, but misuse as well. That's the point, and that much I can. Second is all the hospitals, primary, secondary, private, have given a notification by the West Bengal government. Any persons coming from Bangladesh, no discrimination. Municipal hospital charges the same rate I face and a Bangladeshi person face. There's no discrimination. That's the point, maybe noted here. And regarding the one which I wanted to just to add, yeah, the last one. Many may not be aware that, you know, in my back home, there are something around 500 to 600 Indian students. They come in Bangladesh to the bachelor degree in MBBS, 500, some odd numbers, you know. You don't need to, every year. When they go back, they have to clear the test for the equivalence of degrees they pick up. So we haven't done mutual recognition. Indian government issued a notification in 2022. Anybody is going to the US and Europe, their degrees and diploma in medical science, they have now made an equivalence. And that has happened because of the Russia-Ukraine, because lots of students, they go to the Ukraine and they have to, you know, cut short and come back. So government forced to sign the MLs. So, but we haven't done with the Bangladesh and South Asia context. This is an area, you know, lots can be done.
Excellent, excellent suggestion. So coming to Nepal, short intervention. I mean, how do you see Nepal? Are the politicians open to taking up health a bit more seriously? What's your assessment?
Okay. In fact, there, I think from last 5-6 years, there is a program of health insurance. But it is started in some areas. But it is not, you know, performing well. There are a lot of issues. So, even for example, in Kathmandu city, Kathmandu, we don't have insurance. So like that, it is just started, and the progress is not well. So we really need to implement this insurance scheme. But yeah, as I said earlier, the government has program in budget and program. There is some program related to this, to such type of programs, health programs. But the fund is not enough to carry the program activities. So that's the funding is a problem in our. It means that as you said, the government is not very serious, or what? How can I explain that? Because it is not in priority. It is in total, the percentage of health expenditure is very less. I mean, so that's the issue.
Okay. Your
Yes.
health insurance program is not compulsory, it is voluntary, right?
Is voluntary. Is voluntary.
Yeah, the voluntary insurance mechanism.
Yes.
All right, so we have had a great panel contributions and a very rich flow discussion. I think we have got some good analysis of where the health agenda stands in South Asia, but also very focused and very helpful suggestions about where possible regional cooperation might be pursued, which also might require looking at domestically and getting some things right. So to sum up from my side, what I would say is that the issue of platforms has come up quite a bit, and I think we are not talking of a single platform. You know, SARC is dead. What can we do? We can spend, you know, another 3 days on discussing how to revive SARC. I was on the SARC Poverty Commission, and since that time, it has really gone more quiet, if I may be generous. But I think nevertheless, the discussion about platforms should not be tied to narrowly to a political discussion about SARC, because we see that the platforms, there are multiple avenues in which to pursue this discussion about platform. We've had, for example, Shekhar Shah had this very interesting idea that why energy sector in the South Asian context has benefited from a type of platform which is the regular meeting of power secretaries. Is there a moment which has arrived where the health secretaries regular meeting, but it would not be enough if uninterested health secretaries are sent on a holiday tour to Bangkok or to somewhere else. They have to be interested. And getting them interested is an initial job which has to be done. I think the power sector, because of its centrality to the economic agenda, I think the interest was easier to generate. So I think this is one example of types of platforms that we'll have to pursue. The learning from the health cards, I think, because just as we have good initiative from Sri Lanka, way ahead in terms of systemic improvement, we have also more discrete initiatives like health cards, the Kerala, the Shapna Shastro Shati example in West Bengal, and I think the Modi, there is some Modi program also, isn't it? The health insurance program, etc., etc. In the Bangladesh context, we have, the Shastro Surakha Karmashuchi SSK. It has not really progressed very well. There's some in the rural areas it has been introduced yet to. So, I mean, the choice for the countries in South Asia is at one level, the Sri Lankan type of example, we are able to take it at a systemic level. But I think the political reality of South Asian countries individual is that we may also should be concentrating on this slightly lower level platform opportunities, windows, which can be, which can produce some results in the shorter run. Because getting the system in place may itself become a non-starter if the ingredients are not there. So which are the platforms? For example, education. That's a great area to look at. And as you rightly said, that first we need to look at nationally before we talk of regionally. It's an absolutely important area because the Bangladesh now is facing a problem that we have had this great success in earlier MDG era health indicators, but on SDG era health indicators, Bangladesh is actually floundering on multiple areas. And one of the reason is very much the question of the health workforce, the quality of the health workforce, and that is to do with the quality of the education. Very critical. I think that's something that one can look at, because at the end of the day, that's also one of those critical infrastructures, the workforce. If it isn't there, you may have the policy, but it will not deliver. I am not sure about the other countries also. I have seen that in Bangladesh, there is a sort of is beginning to break, but still we have a stigma burden on the allied health services professions, nurses, technologies, etc. And therefore, the type of social attention which can come on this is a problem, and we are seeing it in the workforce ratio. The doctor to nurse ratio is completely absurd in the context of Bangladesh. What it should be is totally the opposite. And partly because perhaps these professions are not getting that social prestige or social attraction which should be getting. So I think that's also something we really need to look at. I think the health discussion certainly cannot just be limited to healthcare, particularly post-COVID, post-climate change. Health discussion only makes sense if it is about healthcare, but it's also about public health proper, meaning WASH is central, very important. We can bring in nutrition also on the sideline, but the preventive areas, NCDs, preventive issues are also so critical, which means that lifestyle is a critical issue. Urbanization is a absolutely linked issue to health. If you don't have cities which provide those potential for healthy lifestyles, you are going to get more patients for heart attack than your system can ever deliver. So we have to really work on that route also. How do you generate healthy lifestyles? And that's something I would say that we really need to look at. Certainly the private sector has to be brought into this discussion. One, they are doing on the pharma production is very important, but the fact of the matter is 50% out of pocket in Sri Lanka. In Bangladesh, it's over 70% now, the out of pocket expense. I don't know about Nepal and India and others, but I'm sure it should not be too much lower than that. So the cost of medicine is a big barrier to achieving universal health coverage. I think that's something, and getting the private sector into the discussion is also very important, because we can find out where they also become an appropriate stakeholder. I think the whole discussion about regional cooperation, it is pushed too strongly in a public good sense. We may not be able to expand the stakeholders too greatly. We have to, certainly it's a public good, but I think the language, the way we frame the agendas, we have to make sure that entities like the private sector are brought in, the political class is brought in, they also find a entry point to get engaged on that particular issue. And I would end on the last point about politicians. And to Hamid, I think the professionals are as important than politicians. I hear you every time that where are the politicians? It doesn't matter if the politicians are not here. As long as professionals being here, if we have been able to develop a compelling message, that is a first step, because then the politicians may have to listen. But certainly, we have an uphill battle in South Asia, I feel, that I think the simple statistics of GDP percentage on health is a shorthand indicator of the political priority given to health. And I think on that, we have a great, or rather really big challenge in front of us. How do we convince our people that health is a strategic agenda, particularly post-COVID and post-climate change, and improving the resource attention to health and the political attention to health is as important as the power sector itself. And the health secretary should find occasion to meet and, in a way as a indicator. So I would like to end there and thank everyone, and CPD of course, for making this discussion possible. I think the health should not be seen as a sort of a secondary agenda. It is as critical, and particularly post-COVID and post-climate, it is as important as economics, as important as power, infrastructure, or any of the other mega subjects actually. Health is also a mega subject. On that, I'd like to end it here. Thank you.
Thank you, Chair. Thank you, panelists.